Hello, hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, September 2nd, 2018. And you know what that means is it is the start of IC Awareness Month. September is IC Awareness Month. September is the month that IC patients gather together to discuss all things IC. Because this is the time that we tell our stories. This is the time that we advocate for the needs of IC patients. This is the time that we educate our communities. This is the time that we reach and look for doctors who are compassionate about IC. And so my friends, my fellow IC friends who might be watching this is your time to tell your story. This is your time to kick you know what. It is your time to share your truth. There is no more important time for you to do that than it is right now during IC Awareness Month. So please, if you can come on over to icawareness.org and check it out, that's great. Now, I wasn't planning on doing a support group meeting today. However, hello, Lisa. Hello, Sherry. How are you guys doing? Very nice. Hope life is treating you well in Alabama. Out here in California, it is a lukewarm day and it is smoky. It's not too bad, though. We can actually see blue sky, which is good. We haven't had a lot of blue sky this summer. But anyway, if you could please go onto your IC support groups on Facebook and please let them know that we're doing a live meeting right now, because my intention is to talk about the breaking news that I released last night, the discovery by researchers at the Emory Eye Center associated with the Emory University have discovered that some IC patients appear to be having some retinal diseases that may be linked to the use of Elmiron. So because this is important, and hello, Amy from YouTube. We're simulcasting on Facebook and YouTube. And I know it is Labor Day, and I know that we're probably not going to have quite as many people here, which is fine, because that allows me to take your questions. And I like to take questions, right? I like to take questions. Alrighty, so if you have questions, please go ahead and ask them in your comments. In the meantime, let me just do my thing here, because I actually have the papers that and the research studies that were used in the Elmiron announcement last night. And so I wanted to take some time to do that, because I know some of you might be very disturbed, and I certainly was very disturbed myself. And so let's see. Oh, you know what? Can we do a sound test here? Hold on a sec. Let me plug in my microphone. I almost forgot to do that. All right, testing 1, 2, 3. How is the sound, my friends? Can you hear me well? Does it look good? Sound good? So again, if you have any questions, please feel free to ask them. I am happy to take them. Hello from Germany. Awesome. Very nice to meet you, Julianne. How cool is that? Hello, Paula. Hello, Amy. Hello, Annie from New Mexico. I have never been to New Mexico. I would love to come to New Mexico. Chris, hello. One of my deepest, dearest IC friends is Chris. He is in here, and he says, besides pepperoni, what other pizza toppings are particularly bad for an IC bladder? I think pepperoni is pretty much the worst. If you can avoid pepperoni and maybe just do sausage and mushroom or veggie, we are good, my friends. We are good. But pepperoni is kind of the king of processed meats with massive amounts of chemicals in them and nitrates in them and spices in them that have the potential of being irritating to your bladder. And so just maybe we want to stay away from pepperoni. That's how I feel about it. Okay, so I'm just going to get right into it. I released last night a a blog that was very, very scary to write for me. I'm just going to tell you right now. This is one of the most daunting topics I have ever tried to cover in the IC world. I should introduce myself. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. The IC Network is the largest IC support group in the world. We have more than 50,000 members. Been doing this for 25 years, sit on the U.S. Army IC research panel. And I'm very blessed that I have a couple of different college degrees that kind of match perfectly for this, because I have degrees in chemistry, pharmacology, drug development, and a master's degree in psychology. And I was moving on to my PhD in psychology when I got IC myself, at least bladder pain so much that I couldn't drive to school to actually finish a degree. And the IC Network was my doctoral dissertation proposal of how to bring support to patients who are homebound. And it is very comforting to know that 25 years later, we remain, and we always have been, the top website dedicated to IC in not one, but two peer-reviewed medical articles. I want you to know that I take my job very, very seriously. The most important people in my job are you, the IC patient. I am an IC patient. I think that anytime we find information that can affect our health, you have the right to be informed so that you can make good decisions about your health. So let me tell you what happened. On Thursday, I was talking with one of my staffers, Stacy, who writes a lot of the stuff on our website and on our magazine. She and I write most of what we do. We were just brainstorming ideas on what we wanted to cover in future IC magazines and on our website. And I went over to the National Library of Medicine and saw a interesting comment. There had been an article in the Journal of Urology that was talking about new diagnostic criteria for clinical trials for IC. And it was a response to that article. And because I respect the authors of the original article, I thought, you know what, I want to read this. So I go over to the Journal of Urology, which is it's only urologists can read it. You have to really have, and I'm not a urologist, but I have urologists who give me access. So I went over to the journal and read it, and I was stunned speechless. Stunned speechless. This was Thursday afternoon. And I have it right here. Okay, and you can see that it is a response to this one article. It's only 3 paragraphs long, but I want to read it to you. Okay, so to the editor. Now, I want you to understand the context here. This is an article sent by ophthalmologists, researchers from the Emory University Eye Center. And they had concerns and data that they wanted to share with the urology community. And this is an unusual way to do it. But what they did is they wrote a letter to the editor of the journal about it. And I'm going to read you their letter to the editor. It's a little academic, but again, I think that you have the right to know. To the editor, we read, okay, and again, remember the context. They're responding to an article about clinical trials, okay, but they're not going to talk about clinical trials. They're going to talk about eye stuff. So to the editor, we read this article with interest. As mentioned by the authors, only 2 FDA approved therapies for interstitial cystitis currently exist: oral pentosan polysulfate and intravesical DMSO. We wish to alert readers to a concerning new observation of vision-threatening retinal changes associated with a long-term exposure to pentosan polysulfate. And guys, pentosan polysulfate is the scientific name for Elmiron. Elmiron is the brand name. We recently reported our findings of retinal pigmentary changes in 6 patients undergoing long-term therapy with pentosan polysulfate. They briefly described difficulty reading and or trouble adjusting to dim lighting. Each patient had received a standard dosage of pentosan polysulfate ranging from 200 to 400 milligrams a day for a median duration of 15.5 years, a range of 12 to 20 years, for a median cumulative exposure of 2.26 kilograms. So what that means is that's the total number of grams up to the point of kilograms that a patient was exposed to. Examination findings in patients with this condition are suggestive of injury to the retina and the underlying retinal pigment epithelium. Although we have yet to establish causality, the presence of these highly unique retinal findings in this population demonstrates a strong association with long-term pentosan exposure. These cases were identified during a brief 2-year period at our university-based specialty clinic for acquired and hereditary retinal diseases, where we are accustomed to evaluating rare retinal diseases. After extensive investigations, which included molecular testing for hereditary retinal disease, we found these cases to resemble no other known retinal disease. Furthermore, we are unable to postulate a pathophysiological mechanism linking IC itself to these findings. Pending further investigation, it remains unclear whether drug cessation will halt or alter the course of retinal disease. However, we encourage drug cessation in affected patients. Furthermore, this really upsets me. Really upsets me. Furthermore, God, I didn't know I was going to get emotional. I'm sorry. I've worked with IC patients for a long time. And I just have to say that I'm stunned. Okay. Whew, sorry. Furthermore, we currently recommend that any patient with suggestive visual symptoms undergo a comprehensive ophthalmic examination with optical coherence tomography and fundus autofluorescence imaging, regardless of exposure. These recommendations will undoubtedly evolve as we learn more about this concerning finding and may involve routine surveillance, examinations of predefined levels of drug exposure. In the meantime, we are hopeful that ongoing investigations will yield additional therapies for long-term disease control in patients struggling with the symptoms of IC. Okay. Whew. Now my mascara's running. You know why I'm upset? I'm upset because I know so many of you have tried this medication and have relied on it and use it. And we had nothing. We had no clue. Now again, as these researchers say, we are nowhere near at the point where we can say that pentosan makes this happen. Okay, this is very, very preliminary research. But at the same sense, it is deeply concerning to the point that, as you just heard, they said that if you are experiencing eye issues, you need to let your ophthalmologist know that this research has been released, and that they suggest stopping the medication, right? Okay. I didn't know I was going to get this upset. I'm upset. I'm upset for you. I'm upset for everyone. Okay. So ignore my makeup here. So the authors of that original study that they were replying to responded. It's Robert Muldoon and Curtis Nickel. Whenever somebody writes a letter in response to an article in the Journal of Urology, the authors normally respond. Okay? So they responded, and I want to read you their response. And I'm just going to say right now, there are going to be people upset with me. You know, they're like thinking this needs to stay among urologists, and I completely disagree. I think that you, the IC patient, need to know so that if you can make informed decisions. So I'm expecting a backlash from this, and I don't. Hey, you're more important than anybody else. And to me, as soon as Emory University said, if you're struggling with eye issues, you need to get additional care and perhaps stop the medication, that was the moment that I realized that I had to write this blog. Okay, so I want to read you the response that the articles, the IC experts responded to this. And there's a little tiny area that I can't read, and I apologize for that. It's a little link. So Pierce et al., who are the authors of the first one, are looking for a platform to let the urology community know about their observations regarding long-term use of pentosan polysulfate, Elmiron, and potential ophthalmological complications, so much so that they have used a letter to the editor concerning our recent article on the FDA BRUDEC criteria for IC syndrome as a pretext. While the letter has nothing at all to do with our article, we are happy that they have the chance to present their observations. They describe a toxic maculopathy characterized by symptoms of difficulty reading and prolonged dark adaptation in patients on pentosan polysulfate for a median exposure of 15 to 16 years. The association is quite clearly laid out on their publication in Ophthalmology, and they continue to identify more cases in their clinic as well as in the clinics of their colleagues. Pentosan polysulfate, which received conditional FDA approval in 1986, has been prescribed to tens of thousands, perhaps hundreds of thousands of patients with IC-BPS. The optimal dose, pharmacokinetics, mode of action, and even efficacy remain unclear, although safety was never considered a major issue. Many patients with IC-BPS remain on this medication for years and even decades. It is quite unlikely that urologists treating patients with IC ever would have made this association. Even ophthalmologists have difficulty differentiating it from other similar macular disorders. Yet the implications are either frightening if our treatment is causing this condition, or instructive if this condition is a previously unknown manifestation of IC. And then I can't read this one section, although I could log on and get it for you and read it. It's just 2 paragraphs. Basically, they say we would propose a simple large-scale survey of patients with IC to, anyway, obviously to assess this further. If there is any clinical signal, or if ophthalmologists continue to identify this rare condition in patients receiving long-term pentosan, it is imperative that we undertake, along with our colleagues in ophthalmology, a large multi-center screening study of patients with IC, including a cohort of those who have been exposed to pentosan for a long period. We should not let this important observation be relegated to the dustbin of misleading urological associations without being sure it deserves to be there. So what they're saying is they're taking it seriously. They're taking it very, very seriously, and they say more research should be done. They correctly say this is rare. This is rare because Emory University, in their publication, although they identified how many patients in their clinic, I think they identified over 30 patients in their clinic, IC patients. They only had done examinations for 6 of them. So they presented a case series of 6 patients, IC patients, who were experiencing eye problems. So, all right, that's weird. Okay. Okay, so that was the urology community's response is, yeah, we better investigate this further. So anyway, again, Thursday night, I'm reading this going, holy hell, what, you know, it's the most stunning piece of news I've had in 25 years about IC treatment. So then I paid the $40 to get the article. And here's the article. This was published in the Journal of Ophthalmology last May. Pigmentary maculopathy associated with chronic exposure to pentosane polysulfate. In the blog on our Facebook and on our website, I have a link to this. I cannot copy it and send it out. It is obviously copyrighted. However, if you are an IC patient taking Elmiron and you have had eye problems, you need to immediately let your eye doctor know about this paper so that they can get it out of their journal. I'm sorry, I'm just reading some responses here so far. Okay. So just to kind of clarify, a maculopathy is a condition of the macula, an area at the center of the retina associated with highly sensitive and accurate vision. Pigmentary maculopathy means that there are pigments, changes in coloring associated with some of these cells. And in this article, it's a case series of 6 patients who were seen by a single investigator at the Emory Eye Center between May 1st, 2015, 2017. They have all the case information, the patient information. They were women. They were all women. They were all white women. Not that that matters. Most of them were in their 60s, although there was one who was 46 and one who was 37. Their average use of pentosane was about 15 years. Their symptoms were difficulty reading, blurry vision, difficulty reading, looking in the dark. They call that dark adaptation. One patient had what would normally be straight lines, curvy lines. They have you look at a grid, and if the grid is straight versus if the grid is curvy. Curvy means that those cells in the retina are being affected. And then some patients had little bits of vision loss. Interestingly, of these 6 patients, the patient who had the worst damage was actually the youngest patient. I found that particularly interesting. Diagnosed at 24, started Elmiron around the age of 24, had her first eye symptoms when she was 30. I can give you, let me show you. What they did is they did exhaustive testing. They looked for any potential genetic cause, any heredity. So did it run in their family? Did they have any pathologies? Did they have any genes linked to it? None of them did, which led them to conclude that this was a brand new entity. And as they say in their letter, they have never seen anything like this before. They cannot correlate it with anything else. And to give you an idea, I can show you 2 pictures. These are let's see. This is from the youngest patient, actually. Okay, so this is an infrared scan of her retina over time. And so this one is the earliest one, and you can see that it did slowly get bigger, okay? In their discussion, they kind of summarize what they did, and basically they say they described a unique pigmentary maculopathy in the setting of chronic pentosane exposure as seen in 6 patients over a 2-year period. Patients reported difficulty reading, prolonged dark adaptation, and demonstrated characteristic fundus and retinal imaging finding like the picture I just showed you. These findings suggest, let's say, It's very academic. I want to try to simplify it for you. Know that these researchers are specialists in rare diseases. So believe me, they looked for any and other possible rare disease. They could not find any other disease connected to it. Trying to understand the mechanism of action, why would this happen? And that led them to perhaps, again, we don't know. None of this we know, guys, people. We're guessing. Everybody is guessing. But it's informed guessing. And we need a lot more research. But they suggest that perhaps it is a byproduct of the Elmiron or Pentosan that is building up in the eye. That is one theory. Of course, another theory, one of the questions, actually, let me say this. As they were doing this research, they did go back to the time that Elmiron went through FDA approval, and they found a clinical trial that I personally had never seen. It was a clinical trial, 2,499 patients who received Elmiron for up to 4 years, who did report some vision-related adverse events, including optic neuritis, amblyopia, and retinal hemorrhage. So we have one other early study that did find that Elmiron use was linked to some eye issues. They say it is premature to conclude a definite causal relationship exists between Pentosan and this maculopathy. However, this condition, this unique condition to our knowledge, does not resemble any previously described hereditary or acquired maculopathy. And last but not least, one of the things that people would ask is, well, maybe this is just a really weird, maybe this is a weird symptom of IC that nobody's ever uncovered before. And yet we have absolutely no, as they say, we are unable to hypothesize a pathophysiological link between IC and retinal findings. In other words, we don't have any data at all that would suggest that a bladder issue or a pelvic floor muscle issue could affect the eye. That is their opinion. I happen to agree with that opinion. Obviously, we've got some patients have related conditions. They look to see if those could be contributing. They could not find a connection. And they concluded that clinicians should be aware of this condition because it can be mistaken for other well-known macular disorders, such as pattern dystrophy and or age-related macular degeneration. And they urged additional research. I want you to look at me as somebody who gives you comfort and hope, education, information, a reality test. I could not sit on this. I could not sit on this. I believe that you, the IC patient, have the right to know that we have researchers now who are wondering if long-term use of Pentosan is linked to some retinal eye disorders. It is urgent that we develop more data. It is urgent that we explore this. And it is even more urgent if you, as an IC patient, are having eye issues, especially if you've used a Pentosan. If you have, it is very, very important that you let your ophthalmologist know about this study, and so that they can look at this and explore this further. I want you to note that in the letter to the editor they wrote, they suggested that patients with eye issues taking Elmiron should stop taking Elmiron. Now, I dropped this story at 10 o'clock last night, and I want to apologize profusely for dropping it on a weekend, especially when you cannot potentially call your doctor until Tuesday. I don't think that there's a right time or a right place for it. I just knew I wanted to get it out as quickly as I could. Hello, Claire from Scotland. Very, very nice to see you. Hello, Julianne. Julianne, on our website, the IC Network, you'll find a blog which has all the links to all the studies, all right? I think you had the right to know this. I refuse to sit on it. I refuse to sit on it. If you are currently going through any eye issues, you need to let your doctor know. So anyway, I dropped the story last night at 10. And the response has been fascinating. And I want to read a couple of these responses to you. Let's see. I mean, quite a few patients have never taken Elmiron. I personally have never taken Elmiron. Here's somebody who said she's taken it for 4 years, started having very sore, dry eyes, plus insomnia, anxiety, and tinnitus. Obviously, she's not having that. Let's see. Christina reports that her cornea is peeled off. Obviously, that's not discussed, but that's very, very unusual. And I think her ophthalmologist should know about that. Sean, on our website, took Elmiron for 5 years and was just diagnosed with drusen, which is fatty deposits on the retina. Again, that's not specific to this study, but I think that ophthalmologists should know. We've had a couple of people from Emory itself in that study contribute. One had very good eyes, one didn't. There are many, many responses here. Here's somebody who said that Elmiron, while she was on Elmiron, her eyes deteriorated very rapidly. Somebody else who was noting her eyesight was getting worse while she was on it. It's a 35-year-old on her 8th year of Elmiron who developed macular degeneration. Here's another patient, macular degeneration. Somebody else who was just diagnosed with idiopathic parafoveal. I can't even pronounce the last word, also an eye issue, but she had never taken Elmiron. So, you know, we have to correlate the Elmiron with not. Remember, there are heredity issues that can cause eye issues also, toxicities that can cause eye issues. Here's somebody who said took Elmiron for years and she does have a change in pigment of her retinas and the doctors don't know what caused it. Another patient has taken it for years, can't live without it, but her vision has deteriorated. Here's another patient who's now developed sensitivity to bright lights and blurry vision, one of the first symptoms that they noted in these IC patients. Okay. It's very new. We're just trying to understand this now. I don't want you to be frightened. There's no reason to be frightened. We are not talking about life-threatening effects here in any way, shape, or form. You have the right to be concerned because, believe me, I am very, very concerned myself. So what I want you to do is I want you to come over to our website and I want you to read the blog I wrote about it. I want you to print out the blog I wrote about it. I have the references to all 3 articles, the first letter to the editor, the response to the letter to the editor, and the Journal of Ophthalmology. I want you to give those to your urologist because urologists don't know this. This is that new. Believe me, 99.99999% of urologists never saw that letter to the editor. So let's get it to urologists. Let's inform them so that they can check for other patients. I want you to get it to your ophthalmologist. Let the ophthalmologist know that this is pending research. And if you are noticing any changes in your vision, I don't want you to ignore it. I want you to act promptly and quickly. I mean, if you're not starting to notice blurry vision, difficulty reading, anything like that, make sure you get an ophthalmologic exam. And again, remember what those eye researchers said, that if a patient is presenting with eye symptoms, they suggest stopping the medication. So the question is, and I want to kind of point some stuff out here. Some people on our Facebook page in response to this were saying, but it's the only medication for IC. I don't want to stop the only medication for IC. And I want to say, hell no, it is not the only medication for IC. Seriously, it is not the only medication for IC. Number one, please remember that we are now using something called subtyping. Not everybody is the same. There's tremendous diversity in the IC patient. Not every patient has bladder wall dysfunction. And I truly hope you've watched some of these other support group meetings and that you know about this subtyping system. And in fact, you know, let me just get out my slides here. So yes, 20 years ago, 25 years ago, everybody thought IC was an incurable bladder disease. Okay, we no longer think that, people. We no longer think that. We now think of IC as a pelvic pain syndrome. Why do we do that? Because we know now for many patients there are issues going on outside of the bladder, typically with the pelvic floor muscles. All right, so here we go. So we are long past the days of thinking that Elmiron is the only treatment for IC. It is not. The way we focus and talk about treatments is first by trying to understand your unique presentation of IC, right? Why do we do this? Because there is very clear variety in the IC patient population. You got some patients whose bladders look like bloody hamburger, right? You've got other patients with a completely normal bladder like me. Both could be diagnosed with IC, and yet clearly we are not the same. You've got some patients with terrible pain, others with no pain, just frequency urgency. Both could be diagnosed with IC, yet clearly we are not the same. We got some patients with related conditions like irritable bowel and vulvodynia and prostatodynia, low thyroid, ovarian cysts. Other patients with absolutely no related conditions. Both could be diagnosed with IC, but again, clearly they are very, very different, right? And when you get to a meeting and you meet other patients, you see the variation far more clearly when you ask patients what triggered your IC. Because for some people, for women, it can begin after having a baby. For others, it can begin after chemotherapy. For some, it can begin after an infection. For others, it can begin in childhood. All of those could be diagnosed with IC, and yet clearly they're very, very different. So I don't want you to think that Elmiron is the only act in town, nor do I want you to think that Elmiron is the right therapy for you, because we're now trying to subtype. And you may have a different subtype that won't need Elmiron anyway, right? So I use it. There have been several subtyping systems that have been created. One's called UPoint. UPoint was created at the Cleveland Clinic and up at Queen's University in Canada. And it, in fact, is a subtyping system used in the Canadian Urological Association guidelines for IC. Subtyping is not new. They've been around for 10 years. We have the input system. I happen to like this system. It's created by Christopher Payne, who ran the Stanford IC research program for 25 years. And his subtyping system is, I think, the best for educating patients like in this meeting. So I'm going to go over those really quickly. Number one, if you have Hunner's lesions, that is IC subtype 1. Everyone in the world agrees. Every researcher in the world agrees. The patients with Hunner's lesions are distinctly different from everyone else. Why? Because we look at your biopsy results. Your biopsy results are distinctly different from everyone else. Hunner's lesions require lesion-specific therapy. So if you've got Hunner's lesions, the treatment goal and the treatment priority for Hunner's lesions is lesion-specific therapy. That means a steroid injection into the lesion to calm the nerve, or laser therapy of the nerve to silence the nerve, or Lyris, the new medical advice. You will see that there's no Elmiron, no Pitocin involved now in the treatment of Hunner's lesion because it just doesn't make sense. Hunner's lesions have now been connected to potentially 3 different viral infections in some but not all patients. We're still trying to figure out, I mean, there are mysteries about Hunner's lesions, but the whole viral connection is very, very interesting. And it kind of helps us understand why Hunner's lesions might recur. So if you have Hunner's lesions, we're looking at very, very specific therapies. Okay. And obviously you're still going to be following the diet. In fact, it's probably the most important that you're going to be following the diet because you got big wounds in your bladder. And the last thing we want to do is put acid in the wounds. IC subtype 2, bladder wall driven. These are the patients whose symptoms begin after some sort of bladder wall injury or trauma. Chemotherapy is a perfect example. Patients going through chemotherapy have an irritated, damaged bladder wall. But there are subtypes in here. There can be also come from hormones, menopause. If you don't have a lot of estrogen in your bladder, then your bladder mucosal barrier is going to be thinner and your bladder is going to be more vulnerable. I'm kind of rushing through these here, guys, because I want to get to your questions. This is the subtype that Elmiron would be applied to because it's a bladder coating. And I have, in fact, in my hand here, an Elmiron educational tool that I use frequently. So here's an example of the bladder. Here's your bladder wall. Here's what's underneath your bladder wall. You've got nerves and blood vessels and tissue, and then you've got your protective coating, your mucosal barrier. You have to remember that the bladder is the only organ in the human body designed to hold toxic waste. It's body waste. Urine contains ammonia and urea and all sorts of other things. So how does the bladder protect itself when it's holding bad things? And the answer is your bladder is like your mouth. It is a hollow organ covered with mucus. And that nice thick mucosal barrier is, in fact, the barrier that keeps the irritants of urine off of these fragile cells. So if you don't have a lot of mucus, let's see if I can do this the right way. You can see that the irritants in urine reach where it's not supposed to go. What Elmiron does is puts a coating in here. And it's valid. It makes sense. People, listen, the intention and intent and method of action of Elmiron solid for people with a bladder wall issue. It can help put in a nice chemical barrier that can prevent this irritation. Okay? So Elmiron applies mostly to IC subtype 2 pelvic floor. Bladder wall. IC subtype 3 pelvic floor driven. These are the patients whose symptoms begin after a muscle trauma, falling on your tailbone, having a child, sustaining a pelvic injury of subtype. Their symptoms are being driven by tight muscles. Their therapeutic priority is to restore the muscles and restore blood flow. Again, Elmiron is not a therapy for this. Physical therapy is the therapy for this. This, my friends, is the biggest subtype. IC subtype 4, pudendal neuralgia. This is a nerve injury. This is patients who have muscles so tight they're squeezing nerves. So their symptoms are very movement driven and position driven. That you're fine when you stand, but when you sit, it hurts, or you're walking, it hurts. Anytime movement is triggering an issue, again, we're looking at muscles. We're not looking at the bladder, we're looking at muscles. Remember, we no longer think of this as a bladder disease. And I see subtype 5, central sensitization. This is my subtype. This is the inherited subtype. And I have already discussed this in depth. But these are the patients who have a more sensitive nervous system throughout our body. We tend to have the IBS, the vulvodynia. A good portion of this is inherited, at least it is for me. It goes back 3 generations in our family. And again, in other videos, I've gotten through this intensely. So I want you to understand that Elmiron is certainly no longer considered the top therapy for IC. Now we really focus on finding the therapy for your unique presentation of IC. And so there may be some of you who might think you need to take it when you might actually have pelvic floor dysfunction, and therefore it doesn't necessarily make sense for you to take it. All right, so I'm going to start taking some questions here. I just want you to know that Facebook sometimes does not let me scroll back. And so please feel free to ask your questions. Again, we have 95 questions so far on Facebook. I'm going to go to YouTube here for a moment. Dana asked me, what do I think about the biofilm urine test? I am incredibly in support of next generation DNA sequencing tests. And so much so that we have built a sister website to the IC network called bladderhealth.org, where we talk about it in depth. Getting back to IC subtype 2, bladder while driven, actually it's bladder pain syndrome subtype 2. Is there a subgroup of these patients who could have a biofilm-driven infection or chronic infection? Certainly. Why do we know that? Because we already know, for example, that patients with Lyme disease often have bladder-driven symptoms because the Lyme bacteria goes to the bladder. And so if you are in if you have any concern that you might have a chronic infection, then absolutely yes, have a next generation DNA sequencing test. You can order it over on bladderhealth.org. I have been working with this company for 6 months now. It is remarkably compelling and informative, and I am in tremendous support of that now. I've always been in support of ruling out infection. We just didn't have an affordable way to do this cutting edge treatment. We do have, test. We do have that now. All right. Amy says that she had macular degeneration before she went in for in-depth studies of my eyes at the Minnesota Eye Institute and was diagnosed with Stargardt disease. I don't know anything about that, hun. I don't know if that has, I don't know anything about it. I am nowhere near an eye expert. I would just encourage you to give that study or the reference to that study to your doctors at the Minnesota Eye Institute, and let's see how they interpret that. Julianne says the subtyping has given her great understanding of symptoms. Awesome. I'm so glad. Jacqueline, I'm going to come back to your question. I'm coming over here to Facebook. I have to expand my window here so that I can do this. Sherry asked, should Elmer patients wean off or stop it immediately? Listen, I'm not telling you to stop your medicine. That's not coming from me. What I'm saying is that what the doctors are saying is if you are having eye issues, they recommend stopping the medication. You need to talk to your urologist before you make any decisions to stop your meds, okay? Let's see here. Melissa says she wonders if this is what happens with Plaquenil. She has to do baseline eye testing prior to taking it and have to be checked every year for the first 5 years. I don't know. I just don't know, guys. I don't know. Again, you need to bring this to your doctors. Holy moly, boy, do I not. Oh, you're seeing the real Jill Osborne in this video right now. All righty. Penny remarks that Elmeron is known for blood thinning. She found this out due to surgery recently. And again, in that early clinical trial that the researchers found about Elmeron, they noted retinal hemorrhaging in some patients. That Elmeron was definitely linked to retinal hemorrhaging in a small group of patients in that first large clinical trial of patients who took it up to 4 years. Brenda says she has dry eyes and get inflamed eye. I have very dry eyes because I have a related condition to IC called Sjogren's syndrome, and I have never taken Elmeron. So you should not assume the dry eyes are the result of Elmeron. I have wicked dry eyes. Yeah, Nancy makes a good point. She sees young children with retinal issues who have never taken Elmeron. You know, guys, this is at this point in time a rare side effect, but it is something you have the right to know about. Catherine says she has Fuchs dystrophy in her eyes, and I've taken Elmeron. Again, Catherine, give this information to your eye doctor. Carol asks, what do you do now? I have a blog on our website where I answer that question. What should you do now? Please come to ic-network.com. It's on the front page. Please read that blog, people. Do not rely on this people talking to learn about this. Seriously, come read the blog. Read the blog because I cite the research. You can print out the blog. You can give it to your doctors. It's got all the references you need. And I have offered some tips on what I think you should be doing now. Rule number 1 is do not panic. You do not need to panic about this. This is not life-threatening in any way, shape, or form. This is rare. At this point in time, this is rare. We don't have the data yet to be able to make any other statement other than that. You need to educate yourself about it. Read about it. I mean, at least read what I've written there. Talk to your doctors about it. Educate them about it. Let them know that this is coming, that this has now been documented. If you're having eye issues, absolutely get to an ophthalmologist. Have them check it out. That is a must. You must do that. And in consultation with your doctor, you may indeed decide that to stop your Pentosan out of an abundance of caution. I have to say a lot of people have stopped taking Pentosan, Elmiron for the last 4 to 5 years because it's just gotten too expensive anyway, and they can't afford it. Many patients have switched over to other medications or other supplements that have a coating effect. And those supplements are, and listen, I'm not selling anything here. I don't want you to think that I'm trying to sell you anything. This is just important information. The products that have a bladder coating effect are going to be heparin lidocaine bladder installations, or Cysto Renew, or Cysto Protect, or Desert Harvest Aloe. Alrighty? If you go back on our Facebook page, back to May, you will see that I printed a slide from the American Urology Association conference class on IC, in which they recommended these as mucosal barrier replacements, as specific alternatives to Elmiron, okay? So there are natural products that have the potential of providing a similar bladder coating effect. And I will repost that slide. I wish I could do screen share because I would just show it to you right now, but I can't do screen share. So Brenda, again, what do you do? Number 1, you ask yourself and have your doctor try to help you understand. Number 1, is your bladder wall driving your symptoms in the first place? Do you have pain? Is your bladder filled with urine that is relieved by urination? If you do, that points to the bladder wall. Question number 2, is it Hunner's lesions? If it's Hunner's lesions, you do Hunner's lesion specific therapy. If you don't have Hunner's lesions, then we instead look at other things. We want to look and see if menopause is affecting it. Maybe you've got low estrogen that might be causing this mucosal layer to get thinner and thinner, right? So they might, if you've got a dry vulva, a dry vagina, then you probably have a dry urethra and a dry bladder. And that's where a coating makes sense. A coating makes sense here to cover up these tissues, which might be more vulnerable because they have less mucus. And instead of Elmiron, you could do the heparin lidocaine, or you could do one of these supplements instead. Holly says she took Elmiron for a short time. It caused a lot of stomach issues and hair loss, so she stopped taking it. That is quite common. Nancy says, what do I take if I do not take Elmiron? Nancy, I don't take anything. And my ICs are very, very controlled. Because I am IC subtype 5 central sensitization, IC subtype 3 pelvic floor dysfunction. My bladder, I had a hysterectomy last year for uterine cancer. And when they did the hysterectomy, they did a hydrodistension to look at my bladder. My bladder is completely normal, completely normal. There's absolutely no reason for me to do a bladder wall replacement when my bladder wall is normal. And in fact, my symptoms are being driven more by sensitive nerves, because hello, redhead, Norway, you know. But my fundamental problem really is really compromised pelvic floor, specifically my left piriformis, and I've got a bad SI joint. It's ironic. It's interesting that pelvic floor dysfunction can cause all the symptoms we associate with IC, which is going to be urinary frequency, urgency, pressure, pain. But there's subtle differences. Bladder wall pain tends to be very sharp and shrill, kind of ground glass, razor blades. For me, when my bladder wall was screaming 25 years ago, it was like sharp fingernails going down my bladder wall. It was awful because my bladder pain started after a chemical burn. I had a chemical burn in my bladder. That's all healed now. Okay. Pelvic floor pain is different. The pain is not sharp. The pain is duller. It's more consistent. It's achier. It has a burning quality to it because a muscle that's working hard is a muscle that builds up lactic acid. You know, if you're going to run around the block or run a mile, your leg muscles would eventually start burning. That's because a muscle that's working hard builds up lactic acid and burns. If your pelvic floor muscles are working hard, they're going to build up lactic acid and burn that. So that burning sensation is very, very consistent with tight pelvic floor muscles. But the hallmark symptom is difficulty starting your urine stream, because if your muscles are tight, it's going to be hard to relax them to let pee out. So people with tight pelvic floor muscles, it's hard to let stuff out, urine, bowel movements, and it's hard to let stuff in, like if you're a woman, a penis. Sex hurts when your muscles are tight. Okay? So anyway, so my daily life is really focused, number one, on my muscles. And number two, obviously, I'm going to protect my bladder because I'm menopausal now. So I still follow the IC diet fairly rigorously. I don't drink orange juice I follow the IC diet. I'm not a fool. Listen, I lived with terrible pain for years. I have no interest in going back to living with terrible pain. So I'm going to protect my bladder at every opportunity. And so, yeah, I protect myself. And you guys, I'm sorry that I'm looking down, but I've got all these windows open and your questions are low here. Okay, so that's me looking at you in the eyes. That's me looking at questions. Sarah says, do you think this could have any positive effect on the IC community? This is devastating news. Maybe it will drum up more attention. Sarah, that is my hope. I do believe that in the long run, this is going to be very positive for a couple of reasons. Number one, hopefully it will force doctors to look beyond the bladder as a source of your pain. You know, listen, we have been working with subtypes for a decade, but 95% of the urologists out there seriously have never taken a class that talks about the subtypes. They don't know what the hell I'm talking about here. You're going to walk in with more information about subtyping than they will. They just don't have the time or the interest to coming and taking the class. So as we say in every IC support group meeting and with every patient that I work with, our number one job is to understand your anatomy. We're not going to make the patient fit the treatment. We're going to make the treatment fit the patient. 20 years ago, yes, Elmiron was the only treatment, and almost everybody was prescribed Elmiron. Today, we don't do that anymore. Today, we're like going, okay, before we can even talk about treatments, we need to understand what presentation you have. Do you have Honus lesions? Do you have estrogen atrophy? Do you have a chronic infection? Do you have something else funky going on with your bladder wall, like a chemical burn, chemotherapy, ketamine? Or do you have a muscle problem? Or do you have a nerve problem? Or do you have central sensitization? And so my hope for this is that this will break the perception that every IC patient should be prescribed this medicine. Just because it's the only oral drug approved for IC by the FDA doesn't mean that it fits anymore. Yeah, it was approved in 1996. We've learned hell of a lot about IC since then. Lisa says, but for the bladder wall subtypes, what do you do? Well, number one, you protect your bladder. You follow the diet. You drink plenty of water. You talk to your doctor. And remember the 6-step treatment protocol for IC anyway. We have this wonderful, beautiful 6-step treatment protocol. Here it is. I happen to have it right here, my friends. This was created in 2011. This is fabulous. Again, this proves that Elmiron is not the only treatment in town. So the American Urology Association convened a panel of 30 IC experts to try to create a standardized treatment algorithm so that patients across the country, if not across the world, are treated in the same logical way. Because we don't want you to do surgery first. We want you to do easy stuff first. So they created a 6-step treatment protocol, and those steps are arranged with respect to the risk of adverse events. We don't want you to do dangerous stuff until you try the easy stuff. Seriously. So in this treatment protocol, step number 1, water intake. Seriously, just drink. Can you make sure you're drinking plenty of water? You know, 6 to 8 glasses a day. Your urine should be a pale, clear yellow. If it's dark yellow or brown, you're dehydrated. Therefore, your urine's more irritating. Or if it's clear, you're drinking too much water. So let's work on your water intake. Remember, water dilutes the chemicals in your urine and makes them less irritating. So water is important, but do not go out of town and start drinking gallons of water a day. That's going to mess you up too. It's going to mess up your electrolytes. Just be normal, 6 to 8 glasses of water a day. And look at your urine color. If it's clear, you're too much. If it's dark yellow, you're too little. You're going for the pale, clear yellow. And I know you know what I'm talking about here. Step 1, diet modification. Please follow the diet. Listen seriously, if it is your bladder wall, do not be drinking acids or caffeines. You need to protect those wounds in your bladder to give your bladder an opportunity to try to heal itself. Also, step 1, supplements. Why are supplements in step 1? Because they have less side effects than the oral medications like Elmiron in step 2. Muscle relaxation, acupuncture. These are all encouraged in step 1 of the AUA guidelines. Okay? And step 2, physical therapy, oral medications, antihistamine, hydroxyzine, low-dose antidepressant, amitriptyline, Elavil. There are many other oral meds like that. And of course, Elmiron is in step 2, okay? But you've got other things in step 2 you can try. Bladder installations, heparin lidocaine installations, and of course, pain management. The American Urology Association is incredibly compassionate when it comes to IC pain, bladder pain. They want your pain treated. They do not want you sent out the door without a pain control plan. They want pain assessed at every single appointment, period. And if opiates are necessary, they support that. They just don't want you to just do opiates. They want you to get to the bottom of the problem. So, for example, if you have untreated Hunner's lesions and your pain levels are massively high, we want to treat the lesions, for God's sake, because when we treat the lesions, the pain usually goes away or improves dramatically so that maybe you won't need to use a lot of pain meds. Okay? Step 3, Hunner's lesion treatment. How are Hunner's lesions treated? Fulguration or laser therapy, steroid injection or Liris. That's what works for Hunner's lesion, not Elmiron. I can think of a couple of doctors who might disagree with me on that, though. But what the research studies show, that these are the ways, these are the methods that reduce the symptoms of IC. That's just not me. This is supported by research. All right, step number 4, neuromodulation. Urgent PC, InterStim Botox. Step 5, cyclosporin. And step 6, obviously, is going to be surgery. This is very, very rare. Now, I talk about these in depth on our website, so please come on back over to the IC Network, and you can learn more about that. But as you can see, my friends, Elmiron is not the only act in town. You should not assume that you will not get therapy if you cannot take Elmiron. But again, what we have to do is we've got to really try to understand your subtype first, right? And remember, this doesn't happen to everybody. This is new research. We're trying to understand more about these unusual but very concerning findings that some patients who have used Pitocin, aka Elmiron, for longer periods of time appear to have some retinal maculopathies. All right, I'm continuing to go through with questions on Facebook. Again, YouTube, feel free to ask those questions. Jill says she went from a 10 to almost no pain as long as you take Elmiron and many other supplements. Took 2.5 years of horrible pain and all kinds of installations and Botox that did nothing, had bladder infections all your life. So as you say, you're taking Elmiron and you're taking other supplements. So that is the magic combination for you. You know, Dr. Parsons, the doctor who invented Elmiron, appeared on a lecture on our website, and somebody asked him, will I have to take Elmiron for the rest of my life? And he said, no. What you have to do is figure out if it's helping you or not. So how did he suggest that? He suggested reducing the dose gradually. If you take 3 a day, go to 2 a day for a week. See if your symptoms, we'll see what happens to your symptoms. If your symptoms don't change, then maybe the Elmiron's not making a difference. If your symptoms get worse, then maybe the Elmiron is helping. So he suggested going from dropping a capsule a day for a week and seeing how you do. And if your symptoms make no change when you're off of Elmiron, then the Elmiron maybe wasn't helping you. If your symptoms do change as you reduce your dose of Elmiron, then Elmiron is potentially helping you. Brenda says, can you have more than one subtype? Absolutely. I'm IC subtype 5, central sensitization, IC subtype 3, pelvic floor primary. I am bladder wall secondary, which means that occasionally my bladder wall speaks out, but not often. Jill says, diet works. It does. Diet works for patients with IC subtype 1, subtype 2, and subtype 5. Mary Jo says she's had no bad symptoms from Elmiron. That's awesome. Not everybody, you know, Elmiron would never have been FDA approved if it showed that everybody was having side effects. Only some patients have side effects. How many subtypes is it possible for a patient to have? Well, I can tell you right now that we're still trying to, doctors around the world are working on their own subtyping system, including the subtyping biopsy results. And so at this point in time, the sky's the limit. So I don't have an answer for you on that, on how many subtypes. I mean, technically I would be IC subtype 5, centralization, IC subtype 3, bladder wall. Those are my primaries. I'm IC subtype 2, bladder wall driven from estrogen atrophy. So I use some estrogen or vaginally to try to give my bladder that little bit of estrogen it might need to produce a little bit of extra coating. I want to say too, I had uterine cancer last year from taking oral estrogen. So you got to be really careful with your estrogen. Nancy says, the last time her bladder looked at was in '94 by Dr. Parsons. My new urology, I've never looked. She said, should I have my new doctor look at my bladder? You know, my position is really clear. I don't like guessing anymore, especially if pain is involved. If you're in pain and suffering, if I'm in pain and suffering, I want somebody to look. I want somebody to look at whatever's hurting and say, please tell me why that is hurting. I am not interested in guessing when it comes to my own health care. And that's one of the reasons why, you know, we discovered that I had uterine cancer last year, is we stopped guessing about why I was bleeding and we started getting the facts and doing tests. And guess what? Yeah, we found something pretty bad. So if what the American Urology Association guidelines say, if your symptoms are getting worse or you're not responding to therapy or you're struggling with long-term pain, they say revisit the diagnosis. Let's take a step back and look at your body again. Let's see if we missed something. Have we missed lesions? Have we missed pelvic floor dysfunction? Have we missed central sensitization? So I'm not opposed to having a doctor take a look in your bladder. I am concerned about how they choose to do it. We no longer do a high pressure, long duration hydrodistension. That's very traumatic to the bladder. Instead, we do low pressure, short duration, much less traumatic tests, give them a very quick look at your bladder without traumatizing your bladder. If my doctor wanted to do a plain cystoscopy today, like literally right now, if I was in the doctor's office and she said, hey, I want to do a cystoscope, look in your bladder, I'd say no problem. Because all they do is numb your urethra, stick a scope in, take a look, pull it out, you're done. It doesn't traumatize the bladder. A plain cystoscope, it does not traumatize the bladder because they're not filling the bladder. The only legacy of that test is your urethra is going to sting for about 24 hours. Peeing is not going to be fun the first couple of times you do it. But that's very different from a hydrodistension with cystoscopy. With a hydrodistension with cystoscopy, they do it in the operating room or an outpatient center. They fill your bladder with fluid. They're going to stretch it a little bit, drain it out, do it again, stretch it a little bit, drain it out, then use a cystoscope and look. For that test, you are always asleep. You should never be awake for that. It is always recommended to be done with anesthesia. And Nancy, please come over to our website, the IC Network, and watch my video on subtyping. That will give you a little bit more info. Laura says, I've had enterococcus for 3 months, 3 rounds of antibiotics, and still have it. Getting ready to start doxycycline now. So, Laura, my friend, you are the perfect candidate for this. Next generation DNA urine testing. You can learn more about it at bladderhealth.org. That is exactly the circumstance where this is recommended, because they don't try to grow the bacteria out. What they do instead is look for DNA in your urine. And the advantage of this test is it will tell you if you have any genes for drug resistance. That may be one reason why your enterococcus is not responding to therapy, because you may be taking the wrong antibiotic for it. This test gives you the penultimate evaluation of bladder resistancy and drug resistancy, and bacterial resistancy to antibiotics. You know, it's getting kind of dark in here. Hold on a sec. All right. Whew. This was a hard meeting to start. I'm just going to tell you right now. Mary Beth says she's taken Elmeron for 8 years. She's developed retinal holes and macular degeneration. So, Mary Beth, you need to take this article and give it to your ophthalmologist. The question is, did you develop eye issues before you started Elmeron or after you started Elmeron? And more importantly, do you have any family history, any DNA history of heredity-linked macular degeneration? Mary Jo, did the makers of Elmeron hide the info? No, I don't think so. I don't think so. I know those doctors. I don't think that they would ever do something like that. As the eye researchers say in their article, it may just be something, how do I want to say this? It may be a cumulative exposure, you know, that there may be this one magic mark, one magic level where when you reach that point, that's when it could start impacting your eyes. And I don't think that anybody, whether they met at Elmeron or not, could have ever predicted this finding. I really don't see any. Well, I wasn't there. I wasn't involved. I wasn't involved with any of the information. I would just tell you that I really think that the vast majority of people that I know that work in the IC research movement have the best of intentions. And I don't think they would ever, ever, ever hide information like this. Tom says, what specific eye tests are needed for IC patients? This is the article. Let me see if I can find that. I know that they were mostly imaging tests. Near infrared reflective imaging, fundus autofluorescent imaging. I mean, that's really the question that your ophthalmologist is going to have to do. But again, I can give you some examples of what they found. So these are the same patients over time. So this middle one is the easiest one. You can see it started out in a small area. Over time, it got bigger, and then over time, it actually got a little bit bigger in this patient. You can see this also in this patient started with a small area. And by the end, it got to be a bigger area. And I really think that that's why they say that any patient with eye issues that medication should be stopped. Erin says she's freaking out. Hun, don't freak out. You can let me freak out for you because I've been freaking out for the last 48 hours. Now we're grounded in facts. We're grounded in knowledge. And the best thing you can do is just learn about it. Come read the blog. Give it to your doctors. This article is published in the journal Ophthalmology. I have a link for it in the blog. You email that to your ophthalmologist or drop the article off, have them get it out of their journal. Otherwise, if you order it yourself, I think it cost me $35 or $39 to get. Let them get it, and then they need to look at your presentation and see if there's any correlations. And I also would encourage your ophthalmologist, if they do think that there's a connection, to reach out to the researchers at Emory University. And that contact information is, in fact, in this article. Mary Jo, it is small, although they have already confirmed that they have found more cases and in other clinics too. So it's not quite as small as we all thought it was, but it is still rare. LID says, how do we know that other coating medications won't have the same effect? Well, when we think about, you have to kind of think about method of action, right? Okay, so when you're taking, so you would think that if you had a bladder disease, they would put the medication in your bladder, right? That when you put the medication in your bladder, you are delivering the medication to your bladder. You are not forcing it to go through your bloodstream, go through your GI tract to eventually, quote, arrive at your bladder. And so, you know, one of the reasons why they invented Elmeron as a pill was to make it easy for patients, because patients didn't want to have a catheter stuck up their urethra for a test. It's a logical assumption. However, even the early studies for Elmeron showed, they're called bioavailability studies. So the company itself at the time tried to determine how much of the medication you take by mouth makes it to your bladder to do anything effective. And the answer is only about 7%. 93%, if I remember correctly, is destroyed by digestion and rendered inactive when you take it orally. So if you have a bladder issue, the best way to treat that bladder issue is with a bladder-specific treatment. And the odds of that medication getting in any great quantity into your bladder, into your circulatory system to potentially reach other parts of your body, are far lower. That is why oral estrogen is so strongly associated with breast cancer and uterine cancer and ovarian cancer, whereas using a little bit of topical estrogen on your skin down there is considered much less safe. Much safer. So I hope that kind of answers your question. So if you're going to use a coating medication, the best way to do it is put the coating right in your bladder, aka a rescue installation. With things like this, the coating ingredients are hyaluronate and chondroitin. And both of those are already natural building blocks of the bladder wall. So you're not dealing with a very small molecule made in a lab. You're dealing with natural. I mean, I know researchers and scientists would pick that statement apart in a heartbeat. Elmiron is a tiny molecule. It is a heparinoid. What it does is it fills in holes. One of the challenges with Elmiron is that it's a small molecule, so it takes a lot of Elmiron to kind of get in there and fill that hole. And I remember somebody saying at some point in time in the last 15 years that because the Elmiron molecule is so small, it's kind of more easily washed out. Don't quote me on that. I don't know where I got that. And I think what this study points to is, can this small heparinoid molecule collect in other parts of the body? And the answer is still to be decided. However, this research from Emory is certainly concerning. It needs to be confirmed. One of the way it can be confirmed is by you guys please filling out the research study on our website, the survey, where we're trying to develop more data on this so that we can open some eyes and get more attention from the IC community, from IC researchers to explore this more fully, including preferably the Elmiron researchers, if they haven't retired by now. Holly says she takes hydroxyzine and amitriptyline at night. Seems to help. Good. I took hydroxyzine for a decade. I love that medicine. It worked really well for me. The only reason I stopped it is it started giving me nightmares. And that's sometimes what hydroxyzine does. All right, let me go back to to YouTube here. Jacqueline says she has urges. She has bad urges when she wakes up, even if it's from a nap. It doesn't happen all the time. What do you think might cause that? So our urgency in the bladder. So your bladder has two distinct nerve groups. You've got alpha afferent nerves, which control frequency, urgency, and you've got C fibers, which control pain. And as you can see here are the nerves directly underneath this tissue here. And so as urine irritants penetrate down, they can start reaching the nerves. Therefore, the first symptom most people experience whenever you have any bladder issues is frequency and urgency, because those are the nerves that you use every single day that tell you when you need to pee. So the first symptom you experience is urinary frequency urgency, and that's generally the last symptom to go away is urinary frequency urgency, okay? So why are you having that urgency at night when you wake up? I would suggest perhaps there is something in your daily life which could be irritating you a little bit more. A multivitamin, drinking a cup of coffee a day, something like that. That's generally what we see. Julianne asks, is DNA sequencing available outside the United States? Yes, it is. The name of the company that we use is Microgen. You can get all the information here. If you are in Canada, well, number one, come to this website, bladderhealth.org, and click on the order link. And they've been getting ready to activate the international ordering. If it's not activated yet, because I haven't checked it in about a week, you can just call Microgen and order it from them if you are from Canada or if you are from Europe. But if you're from America, just come here and do it here instead. Super easy. I also have a list of countries now. States. There are 15 states where you can order it yourself and you don't need a doctor's recommendation. So you can, or doctor's referral. So you can see what those states are right on this website now. Lenora just started the aloe and the marshmallow root. Cool. I just found a new mint marshmallow root tea that I sent up to my warehouse. They're going to try it out. We may start carrying it in the IC network. It looked really good. Catalina says she was diagnosed with IC because she's got a lot of mast cells in her bladder. So that mast cell driven is probably a subtype of bladder wall driven. And if you have excessive mast cells, then we're going to be looking at an antihistamine like a hydroxyzine or perhaps montelukast to help control those mast cells. By the way, I did put a consumer alert. There was a recall with montelukast. If you use that as a medication, there was a recall this week. And let me just get that for you. The manufacturer, Shock of Shocks, somehow allowed another medication to be put into those bottles, and that medication is very dangerous. And if you, it was a labeling problem in their factory. So some bottles of montelukast made by Camber, C-A-M-B-E-R, Camber, have the wrong labels on them, and they actually contain a medication called valsartan. Now the problem is, losartan, L-O-S-A-R-T-A-N. Losartan is often used to treat high blood pressure and stroke. However, it is fatal potentially to embryos. If you are pregnant and we're taking montelukast, you better check that bottle immediately. If it is made from Camber Pharmaceuticals, you need to look at the FDA recall because their mistake is beyond tragic, and we don't want you exposed to something that could harm your baby. Jacqueline says she doesn't do vitamins because she found out they really mess you up. And that vitamin B makes your urges really bad. Vitamins kill me. I mean, they used to kill me. I couldn't take Centrum 1 a day, anything like that. However, we did help. I was having an interesting conversation with the CEO of one of the companies, Far Laboratories, and he asked me, he said, Jill, if you could make anything for an IC patient, what would you make? And popped out of my mouth a low-acid multivitamin. He said, why? And I said, because people ask me every day, is there a safe multivitamin? I say, no, there isn't. And so he called me back 6 weeks later and said, we have made your low acid vitamin, and it's called Multirite. It's a low acid formula. And I can take this, no problem. The majority of patients who have tried it had no issues with it. It does have a little bit of vitamin C in it, but it's not the citrus vitamin C. It is calcium ascorbate, and it also does even have B6 in it. But what's cool about this is that it also has an acid reducing form of calcium in it that will minimize that acid. So if you do want to try a vitamin, you could try this. This is available on our website. However, I'm just going to say right now, I'm not a vitamin girl. They didn't have multivitamins 100 years ago. Do I think people need to take vitamins to be healthy? No, I think you need to eat a good, healthy, fresh, organic diet if possible. But if you're somebody who's very limited with your diet and you don't think you're getting enough minerals and vitamins, then you could try this and see how you do with it. All righty. Dana said, did you say that this was being misdiagnosed as pattern dystrophy? I was diagnosed with this in April. I took Elmaron. Yes, that is what they said, that it could be misdiagnosed as pattern dystrophy, Dana. And so, again, come to our website, get the reference, give it to your ophthalmologist, and have them consider this and look at it. It's worth reviewing. And please also come to the blog I wrote about it, and please take the survey. Because we need to develop that data. It's very, very important that you share that information in our survey so that we can present that data to the powers that be to get them to take this more seriously. Nini says, I've only had frequency urgency for 16 years, and for the past 3 years, you've had pain flares. What would cause a change that the pain nerves are now affected? Well, the pain nerves in the bladder actually are really hard to turn on. It normally takes some sort of trauma to turn them on, like massively overfilling your bladder and holding it. It is far more likely that you are now becoming a estrogen atrophy patient. It may be that your estrogen levels have dropped to the point that you don't have as much mucus in your bladder. And because of that, your bladder cannot defend itself as well. And maybe you've gotten used to drinking some risk foods without understanding that now that you're hormonal and now that you have less mucus, you simply may not be able to tolerate that like you used to. Dina asks, can I explain the symptoms and holistic treatments for pudendal nerve? The symptoms of pudendal nerve entrapment are nerve driven. One of the symptoms is, well, obviously pain that is movement driven. If you're fine when you're standing, but you sit down, it hurts, then anytime movement drives a symptom, we're going to look at nerves being compressed and or muscles being involved. So you're fine when you're standing, but when you sit, you hurt, or you squat down, that you hurt, or you have nerve pain. Nerve pain can present in a couple of different ways. It can feel like electricity. You got a shocking sensation, sciatica going down your leg. That certainly could be it. But one of the more subtle symptoms of pudendal neuralgia is actually PGAD, persistent genital arousal disorder, where you feel this kind of funky, odd, icky, kind of slightly aroused, but it hurts and I don't like this at all. I had it for about a month myself. And that really is just the pudendal nerve becoming very irritated. And so if you're dealing with any funky arousal, painful, weird funkiness like that, very hard to describe. We call it persistent genital arousal disorder. Or what I'm having right now, literally as we're speaking, is when I sit too long, I get a vibration deep in my left butt cheek. It is like sitting on a cell phone on vibrate. And the longer I sit, the worse it will get. And so right now it's a little tiny flickering. And then it's going to get a woo. And that's when I know I've got to sit on my yoga ball back there or stand up. All right. Okay. Coming back to Facebook here. Sorry, guys. But we are simulcasting on YouTube and Facebook. Mary says, no, hold on. I'm kind of scrolling back here on Facebook because we've got 161 comments here. Mary Beth asks, is there any charts or things we can bring to our doctors to reference to your quick subtypes? Yes, you can. We do have one. If you come over to the IC Network, go into the free download area. And we have the fact sheets on IC that you can download. And I have one fact sheet. I'm trying to find it here. We have a fact sheet called the IC subtypes that you can just download right from our website. There are other fact sheets too, the 6 steps of treatment, all that sort of stuff. I love taking your questions, guys. I really, really do. This is the best part of my job. I want to be a source of inspiration and comfort and education for you. I want you to leave meetings like this feeling better about yourself, feeling confident, being able to lift your head up high, being able to look doctors straight in the eye, to have good discussion, good productive discussions about your medical care. I want you to be confident. What I don't want you to do is drop your head and start crying and feel ashamed. There's no shame or blame when you've got pelvic pain. You have done absolutely nothing wrong. Nothing wrong. I don't want you to carry any guilt about this. You're hurt. Whether it's your bladder, whether it's your pelvic floor, whether it's a nerve, you're hurt. It's not your fault, and it never was your fault. Period. End of story. All right. Rebecca says, what's the best treatment for Hunner's lesions? You got 3 treatments. You've got laser therapy or fulguration, you've got steroid injection, or you've got Liris. I think at this point in time, although it is not FDA approved, Liris has the best results because it has healed Hunner's lesions after just a 2-week treatment in some patients. Mary says she was given estrogen to rub on her arm. Does it care of the same cancer issues? I think people would say yes, because it is systemic. It is going into your bloodstream. Therefore, it can reach other parts of your body. But that is a discussion you really should have with your doctor. Jennifer was awake during a hydrodistension. I was also given a hydrodistension without any anesthesia by a radiologist, and I will tell you, I was a blubbering idiot when I walked out of that. I was screaming on the table, and I actually got her fired because she ignored my doctor's instructions. Nancy says she has lesions in the neck of your bladder. Where does that fit in your subtype? Easy, hun. Your IC subtype 1, Hunter's lesions. That is the clear subtype everybody in the world agrees on. Nancy says, can you do a cystoscopy in the office with Valium? Well, you can do a cysto in the office with Valium. I certainly wouldn't do a hydrodistension in the office with Valium. You really need to be asleep for that, because when you stretch your bladder, even a little bit, it can be quite painful. So the American Urology Association suggests that all hydrodistensions be done with anesthesia, and that is not Valium. She also says she has bleeding on the retina. Again, you need to take this article to your doctor. That first clinical study, clinical trial with Elmiron that the researcher cited, did show other eye issues, including retinal hemorrhaging. And let me just see if I can find it here. I have the paper right here. I cite it in my blog article. In a subsequent unmasked, so in a 3-month placebo-controlled study of 258 patients before the FDA approval for Elmiron, there was no vision-related safety signals. However, in a subsequent unmasked clinical trial of 2,499 patients receiving the drug for up to 4 years, vision-related adverse events included reports of optic neuritis, amblyopia, and retinal hemorrhage. Okay? It is unclear if these cases were attributed to the drug itself, but they found it. So the fact that you're having retinal hemorrhaging is important. Adele says regular eye testing and regular blood tests will be part of being on Elmiron. Absolutely. And the blood test is a liver function test. Let's make sure Elmiron is known to sometimes affect your liver, is it liver enzymes? Anyway, liver testing is sometimes requested. Mary Jo, is there a top one of the supplements you recommend? Yes and no. I mean, the reality is we're also individual, that what might work for me might not work for you and vice versa. And so given the fact that we all have very unique sensitivities, you can't really say which will work. It's really a trial and error process. However, I look at methods of action. And so let me give you an example. So Cysto Protec has 2 methods of action. It has a bladder coating effect from chondroitin and hyaluronate combined with an antihistaminic effect from quercetin. Okay. And this is why when this came out 15 years ago, very quickly dominated the IC market. Many, many patients have used Cysto Protec, myself included, successfully. However, it's an old formula. This was invented by Dr. Theo Harides at Tufts University, and we had been waiting for Dr. Theo to kind of create his next generation supplement, but he has moved on. He's doing other things now. He's working with autism. So a new doctor, Dr. Gio Espinosa, who runs the Integrative Urology Department for New York University, 5 years ago created the next generation supplement, and it is called Cysto Renew. And Cysto Renew has 4 methods of action, maybe even 5 methods of action. So what Dr. Espinosa did is he took the best of all the other supplements and put them into this supplement. So this one has chondroitin for the bladder coating effect, quercetin for the antihistaminic effect, It has aloe for the soothing effect of the aloe. And I think it's got L-arginine and L-citrulline. And I can't tell you off the top of my head what they do, except I know I have research studies showing L-arginine has been helpful in 2 studies, but not in 1 study. But I think the genius ingredient of this is a mint called lemon balm. Now, it is not citrus lemon. It is a mint with a lemony scent. But lemon balm is known for its ability to be calming and soothing to nerves. And in fact, that's what a lot of IC kind of doctors have been exploring and probing, is how do we calm the nerves in the bladder and the nerves in the pelvis. And it's been a subject of tremendous discussion at the research level. And so this supplement is the one supplement that kind of has that nerve component to it. But of course, we cannot underestimate the power of just plain Desert Harvest aloe. The reason why I say that is because this is indeed the only supplement company to do a double-blind placebo-controlled study with their product in IC where it was found to be effective. And although it was a small study, it was a valid, rigorous study. So Desert Harvest aloe is known for a bladder coating effect and known to be soothing, especially in the urethra with some of the patients that I've worked with in the urethra. So aloe, so some patients have done this, some patients do this and this. Some patients just do this. Some patients do nothing. It's just, you know, they're food supplements. They're not FDA approved as treatments for IC. The companies are not allowed to say that they're treatments for IC. They are food supplements that are believed to have a beneficial effect for bladder health. So there you go. I will tell you that in all the big IC classes that have been taught to doctors in the last 10 years, these are brought up. They are considered first-line options because they have so many fewer side effects than, say, the Elmeron. So generally in the AUA guidelines, they suggest trying supplements before you try the oral medications because of the much less risk of adverse event. I will say that because we are so sensitive, it is important to go slowly. Take 1 pill and just see if you like it. See if your body feels good. If your body feels good, then do like 1 a day for a week and see if it feels good. If that works, you can work your way up. I'm one of those people where when I tried to work myself up after 1, I could not do it because it gave me loose bowel and my stomach flip-flopped. So for example, when I take Cystoprotect, if I'm flaring and I'm feeling like my bladder's getting irritated for one reason, I would literally only do 1 a day. I'm super sensitive. So you kind of have to be respectful of the fact that your body might be reactive to stuff and sensitive to stuff. I will also say that one of the reasons why supplements have become remarkably popular is because many patients can't afford traditional medications. They don't have insurance. They can't afford. Elmeron can cost $2,000 a month now. And so that's the other reason why patients, and I think at this point in time, we have to be thankful that we have these as options. They're options. Karen just got on. She wants to know why regular eye and blood tests for, okay, so I just want to reiterate here, the reason why I did this is because last night at 10 o'clock, I dropped a pretty alarming a consumer alert on our website and on our Facebook page. I have not mailed it out to our 30,000 people who get our newsletter yet. I will do that this week. I'm not going to cry this time. I cried earlier talking about it. So on Thursday, just to give you context again, on Thursday, I was talking with Stacy. Actually, it was before I talked to Stacy. We were looking. She wanted to know if I wanted any articles written. I did my normal thing. I went over to and looked at the new research. And I saw a little tiny reference to a little tiny letter to the editor, to an article in the Journal of Urology. And because the author of that paper is somebody I respect, I went and read this little letter to the editor. And what was stunning about the little letter to the editor, is that it was from a team of eye researchers at Emory University who believe that they have found a new adverse event for Elmiron, and that is a maculopathy. And so let me just take a moment, and I'm going to read their letter again for those of you who are new. This is breaking news, my friends. This was just published 3 weeks ago, okay? I was stunned when I read it on Thursday. And as soon as I read it, I, out of an abundance of caution, knew that I had to tell you about it, because it, as we have seen in this discussion today, there are patients who may have eye problems. So let me just read this. So this was written by Drs. William Pierce, Adam Hanoff, and Dr. Jane in the Department of Ophthalmology at the Emory School of Medicine. They are replying to, is interesting, they were responding to another article on clinical trial diagnostic criteria. They were obviously looking for a way to communicate to IC doctors, and they chose to do a letter to the editor, which I think was brilliant, brilliant. So they wrote, to the editor, we read this article with interest. As mentioned by the authors, only 2 FDA-approved therapies for IC currently exist. Oral pentosan polysulfate and intravesical DMSO. We wish to alert readers to a concerning new observation of vision-threatening retinal changes associated with long-term exposure to pentosan polysulfate. That is the scientific name for Elmiron. Elmiron is the brand name. We recently reported our findings of retinal pigmentary changes in 6 patients undergoing long-term therapy with pentosan polysulfate. They experienced yada yada, difficulty reading, trouble adjusting to dim lighting. Each patient had received a standard dosage of pentosan polysulfate ranging from 200 to 400 milligrams daily for a median duration of 15.5 years. Examination findings in patients with this condition are suggestive of injury to the retina and to the underlying retinal pigment epithelium. Although we have yet to establish causality, the presence of these highly unique retinal findings in this population demonstrates a strong association with long-term pentosan exposure. These cases were identified during a brief period at our university-based specialty clinic for acquired and hereditary retinal diseases, where we are accustomed to evaluating rare retinal diseases. After extensive investigations, which included molecular testing for hereditary retinal disease, we found these cases to resemble no other retinal disease. Furthermore, we are unable to postulate a pathophysiological mechanism which links IC or the bladder itself to these findings. Pending further investigation, it remains unclear whether drug cessation will halt or alter the course of retinal disease. However, we encourage drug cessation in affected patients. Furthermore, we currently recommend that any patient with suggestive visual symptoms undergo a comprehensive ophthalmologic exam with optical coherence tomography and fundus autofluorescent imaging regardless of exposure. These recommendations will undoubtedly evolve as we learn more about this concerning finding and may involve routine surveillance examinations at predefined levels of drug exposure. In the meantime, we are hopeful that ongoing investigation will yield additional therapies for long-term disease control in patients struggling with IC-BPS. Mind blown? You should have seen me, because then I knew that I had a responsibility to tell you, right? Then some IC experts responded with another letter. And they note that Pitocin received conditional FDA approval in 1986, has been prescribed to tens of thousands of patients, perhaps hundreds of thousands of patients with IC-BPS. The optimal dose, pharmacokinetics, method of action, and even efficacy remain unclear, although safety was never considered a major issue. Many patients with IC remain on this medication for years and decades. It is quite unlikely that urologists treating patients with IC-BPS ever would have made this association. Even ophthalmologists have difficulty differentiating it from other similar macular disorders. Yet the implications are either frightening if our treatment is causing this condition, or instructive if this condition is a previously unknown manifestation. And so anyway, they also ask for additional research. So my intention in bringing this to your attention is, number one, I'm an IC patient like you. I think that we all have to be informed of risk versus benefits. The fact that these eye researchers at Elmiron suggested stopping Elmiron if eye disease was present was a motivation behind me writing the blog that I released last night at 10 p.m. and doing this meeting today. If they feel strongly that stopping the medication in the presence of eye dysfunction could help that patient with eye dysfunction, I believe that you have the right to know that. And that is why I wrote what I wrote. And you can read it right now on our website, or I have a link with it on our Facebook page, ic-network.com. I want you to read it. I want you to print it out. I want you to give it to your urologist. Let's let your urologist know that this is new. I'm telling you right now that how many people could have read this little tiny letter to the editor to this one little tiny story on IC? A handful. So I think, hey, listen, it's IC Awareness Month. Our job is to educate. Let's educate our doctors about this now. Let's at least get them to start asking potentially about eye issues. And if you yourself are having eye issues and you have been on Elmiron, you need to absolutely take this article, which is the actual article of the study, and there is a link to it on our website. This article was released last May. You need to give the reference to your doctor, let the doctor get it out of his ophthalmology journal. He needs to read it to really try to understand if your eye issues are the same that they're describing here. Now listen, this is only 6 patients, but they have already confirmed that they've seen more in their clinic, and other ophthalmologists in their clinics have seen this too. So it's still rare. This is still a very small subset of the tens of thousands of patients who have taken it, but I think you have the right to know this risk. I do. And I know somebody's going to beat me up about it. I don't know who, but somebody's going to chew me out this week for telling you, but I couldn't not tell you. You have the right to know, especially if you're having eye issues. Wow, Nancy might have been affected by the montelukast recall. Ooh, Nancy, ooh, I'm so glad they got that under control. All right, still going through questions. Kelly was diagnosed on August 3rd. She just took an AZO test and it showed some leukocytes. Is this normal? And the answer is yes. Yes, it is. Most IC patients with flares are probably going to have some leukocytes. That does not necessarily mean that you have an infectious process. An azo urine test strip, and let me see if I can find my sample here. Hold on. Here it is. Okay. Whew. All right, so let's talk about this for a moment. Now, I will explain why you have leukocytes. One of the reasons why you might have leukocytes. All right. So guys, you got to remember that the bladder only knows one language: frequency, urgency, pressure, pain, right? So pretty much everything feels like infection. So most IC patients at some point in time go through an extended period of time where you think you're having infections over and over and over again. I did for a year. I can't tell you how many urine tests I had my first year with IC. I didn't understand that that's just the bladder language. I mean, you could have a bullet wound or a stab wound. It would feel like infection because, again, that's the only way the bladder can tell you that there's an issue. So you kind of get to the point where you can't necessarily go to the hospital every time and leave a urine sample. It can be expensive. The doctor might not go for it. So many patients, one of the first thing you'll do to kind of figure out if you do have infection is use an azo test strip, right? So this is what they do at many doctor's offices is you just pee on a test strip and it tests for two things. It tests for leukocytes and nitrites. So here you go. Right? So here it is right here. You've got an upper pad and a lower pad. The upper pad tests for leukocytes. The lower pad tests for nitrites. Leukocytes are white blood cells. Nitrites are a byproduct of infection itself. So if you have positive nitrites, you have infection because nitrites are only produced by an infectious process. Leukocytes, on the other hand, are common in patients with bladder injury. Okay, why? I'll tell you why. It's a really fascinating exercise, fascinating understanding of bladder biology. So let's use this. This is a perfect way to describe it, right? Okay, so let me hold it this way. Let's see. Okay, so here is your blood vessels, and here are your nerves, right? Here's the urothelium, the cells that line your bladder, and this turquoise barrier is, in fact, your first level of protection. It's your mucosa, because your bladder is like your mouth. It's a hollow organ covered with mucus. But if something is damaged, if your mucus is damaged, what happens is the irritants in urine reach this far. Right? They get into the cells. And bacteria can get into the cells too, but many times it's just the acid. It's just something in your urine that has now gotten where it's not supposed to get and is provoking irritation. Well, here's the thing that's so interesting about the bladder. You know, I guess there are a lot of things I want to say, but because I find it all fascinating. Your body can tell if something is where it's not supposed to be. So your body has a signaling mechanism built in here that says, uh-oh, something's wrong. And when that signal gets pushed to a different part of your body, I don't know if it gets pushed to your brain or to your spinal cord, but what happens is your body responds by sending leukocytes to the area because leukocytes are your fighters. Leukocytes are your army. They're your white blood cells. They're the ones that swoop in when you've got infection and try to kill the bacteria, right? So leukocytes are our first degree of defense. So you've got bad stuff getting here, and the leukocytes are swarming up through your blood vessels, and they get to these capillaries. But how do they get from the capillary to here? How do they get there? Well, the answer is the capillaries open and release them. I mean, that's how they don't just break through the blood vessel. The capillaries have a mechanism, I think, that just gently releases them into the tissue where something bad is happening. And I think that's why we have more leukocytes, is because that's your body saying, hey, there's something wrong here. We're trying to investigate. The challenge here is it's not infection. There's nothing to fight. So when they get there, they're looking for infection. They're not finding infection. What they're dealing instead with is kind of the superficial chemical irritation and acid irritation, which they can't really do anything. So I think that that's really why we tend to have more leukocytes in our urine, especially when we're flaring. All right. Okay, seriously, people, please do not stop your Elmeron without talking to your doctor first. You are not hearing that from me. You have to talk with your doctor and talk this over with your doctor first and let them know about it, and then develop a plan with your doctor about what you're going to do if you do choose to stop the Elmeron, okay? Christine's going to see her doctor this week, Dr. Teichman. Dr. Teichman is very well known. It's going to be a fascinating appointment for you, Christine. I don't know if I were to hazard to guess. I'm going to guess 3 doctors know about this. Well, our medical board knows because I emailed them, and 2 of them already knew about it. Okay, but this is very, very new, and it's stunning. It's stunning information. Megan says, do you think they'll come out with more medicine for IC? Well, Megan, the correct question is, will they come out for more medication for the more subtypes of IC? Come on, you can't just use a blanket. You can't just say blanket IC anymore. That doesn't work anymore. So the real question is, will they come out with new medications for Hunner's lesions? The answer is, yeah, we already have one, Lyris, that is healing Hunner's lesions in just 2 weeks. So we already have something very, very exciting for Hunner's lesions. We're waiting for FDA approval now in their latest round of study. Will they come out with new bladder coatings? They're working on it. And in fact, at the American Urology Association meeting 2 months ago, we have yet another new, very promising therapy called platelet-rich plasma, which got very, very good success in terms of calming the bladder wall and reducing symptoms. So that is something very new. Platelet-rich plasma. There's a blog on it on our website right now. Please come on over to the IC Network and you can read that. Are they going to come out with new medications for pelvic floor? Probably not, because it's muscular. The treatment for pelvic floor-driven IC is in fact going to be pelvic floor physical therapy and perhaps muscle relaxant. Same thing with pudendal neuralgia. It's primarily going to be pelvic floor therapy and maybe a nerve calming medication. So your question is a great question, but it's way too broad. Remember, we don't think of IC as a uncurable bladder disease anymore. We now call it a pelvic pain syndrome. Why? Because we now know that there are many variations that we are now calling subtyping. Doctors around the world are now trying to understand and develop new subtyping systems, both based upon your symptoms, but also based on biopsy results. So this is very new, very cutting edge. A lot of doctors don't know about it because they haven't been to the classes or they don't read the journal articles. When you go in and talk about subtypes to your doctor, you're going to get a blank look in all likelihood, but I've got some good references on our website. I also have an article on our website called The History of Subtypes. It's right on the front page of the IC Network that I think you can print out and give to your doctor. I will tell you that the Canadian Journal of Urology IC guidelines are the most cutting edge guidelines right now. And they are based entirely on subtypes, the U-point system. Okay, so let's see here. All right. Suzanne just says, does anybody take D-mannose? Several people have responded. I will tell you that D-mannose is not a treatment for bladder wall driven at all. What it can do is inhibit the ability of E. coli to attach to the bladder wall. It is not considered effective for any other infections. It is not considered a therapy. It is not considered a treatment for IC or infection. It is considered a perhaps prophylactic approach to preventing infections. There's really no usefulness to it for IC or bladder wall unless you are struggling with E. coli-based chronic infections. Sarah says she started Cysto Renew, taking 4 daily, upset your gut. If I'm only taking half the dosage, will it help? Sure. You know, hon, there's a concept in pharmacology that's really important. I think you really need to understand the concept. It's called lowest effective dose. What is the lowest dose of medication that you can take to get a beneficial effect? So if you are IC subtype 5 central sensitization like I am, then you are drug sensitive. Your body is going to react more aggressively to medication, which is why we have to take half doses or quarter doses. So it's not necessarily about the most medication you can take. It's not about, you shouldn't be thinking the more you take, the better the result. And in fact, we know from early Elmiron studies, for example, that taking more Elmiron was not as effective as taking less Elmiron. They did a dose ranging study of 300, 600, 900 milligrams of Elmiron like 15 years ago. And they, obviously the company was hoping that the 900 milligrams would be the most successful because that would help them sell more. But I thought, to their credit, published the results of their study, which showed it actually the lowest dose was the most effective dose. And so you should not assume that more is better with anything. It's really about finding what works for you. And sometimes that's the lowest dose. Okay, so I hope that that helps. William says, do you know how long it should take to get a urine stream started? Literally a second or two. If you don't have pelvic floor dysfunction and your bladder is behaving normally, you can normally pee like on demand. If you've got pelvic floor dysfunction, you're sitting there going, relax. You know, you're sitting there or standing there for a couple of seconds before you can relax enough to let your urine out. For some people, it might be 3 or 4 seconds. For other people, it might be 20 or 30 seconds. After my hysterectomy, I had massive pelvic floor dysfunction and levator spasms, and I just had to sit on the toilet and just kind of breathe and just wait for my body to do what it was going to do, because there was nothing I could do. I was just dealing with a post-op muscle trauma from a hysterectomy. Mary Jo says, if you're having surgery, they recommend not taking Elmiron for a few days. That is true. And for major surgery, in some cases, doctors may want you to be off of Elmiron for 6 weeks. Don't quote me on where that was. Man, that's from a decade ago. Karen says her urologist doesn't know about eye and blood testing from being on Elmiron. Well then, you know, hey guys, it's IC Awareness Month. This is when we become teachers. You are a teacher. So bring in documentation. Prove it to them. There are articles that talk about it, and we now have this article, which I referenced earlier. Again, if you go to our website, go read the blog on Pentosan and I, and it references the original letter to the editor of the eye doctors, the eye researchers sharing their research with Pentosan. It gives the response of the IC doctors to that. And again, these are very short, but most importantly, there is a very long paper, Pigmentary Maculopathy Associated with Chronic Exposure to Pentosan Polysulfate. This was in the Journal of Ophthalmology, and this is the article that they really need to see. Megan, what is the best place to buy Cysto Renew? Why, from the IC Network, of course. We have all the supplements in our store. And the advantage of buying it from us is that you get to help support, you know, you get to help this meeting happen and our publications happen and this blog happen. We are a health publishing company, a medical education company, so we can sell things. And that's how we support a lot of what we do is we have all the books and chair cushions and heating pads and supplements. Nonprofits cannot sell these, but a publishing company can sell these. And that's how we're organized. We've been this way for 25 years. Kellyanne, who should you contact if you are having eye issues? You need to contact an eye doctor. Get a referral from your primary care doctor. Tell them that you've got blurry vision or you can't focus, you're having trouble reading, and you need to get a referral to an ophthalmologist. And ideally, you're going to bring them this paper. Mackenzie asked, does Urabel do that? I don't have any information on Urabel doing that. Lark says she's on Elmeron for 5 years. Have been seeing an ophthalmologist this summer for rapid onset of vision and retina problems. So I really appreciate your timely release of the info. Lark, you're exactly why I did it. I mean, girl, I got to tell you, I couldn't sit on this. I knew that there were patients out there who potentially were having some eye issues, and this is a very, very important piece of that puzzle. And I'm so sorry. I don't know if your eye issues are connected, but it's certainly worth exploring further. And most importantly, I want you to know that you're not alone. And we're doing everything we can to try to get this information out. Karen says she'd like to get off Elmeron. Is there anything less harmful that works? Again, Karen, please go read the journal article. The article that I wrote on our website about it. Please go to ic-network.com or on this Facebook page. I have a link to that article there. While you're on our website, please sign up for our newsletter because you will then get notices like this. And that will give you the references, but I also go over Elmeron alternatives. Blanca says her son, who's just 16 years old, was just diagnosed with IC. So Blanca, seriously, with your son, this is all about subtyping, my friend. And I'm going to tell you right now that the vast majority of guys that I work with have pelvic floor injuries by far. So if your son was an athlete and he's taken a big fall, he was a football player, bike rider, something like that, please, please, please consider getting an examination for any sort of pelvic injury, muscle injury. That's very, very important. In contrast, if he has sensitive skin and he's struggling with food sensitivity, drug sensitivity, smell sensitivity, things like that, then, you know, he might be IC subtype 5 if you have this too. And we don't consider that a disease in any way, shape, or form. I've spoken about this in depth, and I would love to talk with you by phone about this because I would like to ease any worry that you might have or your son might have. You are absolutely welcome to give me a phone call this week. As you see me looking around here, I'm looking for my paper, which has our phone number on it, 1-800-928-7499, 1-800-928-7496. There it is. Guys, seriously, if you've got children who you think might have IC, and we're not talking about eye damage, we're talking about IC, you know, please feel free to give me a phone call. Especially if you feel like it runs in your family, because I think I can explain that. It runs in my family. It goes back 3 generations in my family. That's IC subtype 5. That's not a disease. That is, in many cases, genetics. And I can put that in context for you and take some guilt out of that and give you some really good tips. And obviously, Blanca, for the short term until a diagnosis is complete, definitely get him off the hard sodas and cranberry and stuff like that. Let's just assume over an abundance of caution his bladder might be hurt, but seriously, got to get those muscles checked out. William says, does rooibos tea irritate the bladder? Never irritated mine. That's what this is. This is pumpkin spice rooibos tea that we sell in our store. I love it. Have it every day. Urabel does not have similar ingredients to Elmeron, not even close. So Erin is started Sister Protect. She's getting bladder instills. She's also on Elmeron, but she is struggling with hair loss. And so just know that hair loss is considered temporary. Normally it returns when you get off of the medication. The thing to remember about drug side effects is if a medication is giving you so many side effects that it's interfering with your quality of life or interfering with something that's important to you, then that's when you go back to your doctor and say, listen, this medication is not working for me. What alternative do we have? What else can we do? Tracy says, when I'm in a flare, my feet are cold. Is this common with IC? What's so weird is I'm exactly the opposite. My feet get hot. I don't understand why. One reason I can explain, I don't understand why my feet get hot. It might be a thyroid issue or a Sjogren's issue. But I think one reason why your feet might get cold is because you might have diminished blood flow because your muscles might be tight. You know, when muscles are tight, they start impacting blood flow. Hi, Christy. It's nice to see you. I'm glad that you love our IC awareness pictures this year. Guys, you can buy the AZO test strips from the IC Network too. Capillaries or capillaries. I don't know. I just say capillaries. Somebody's talking about, oh yeah, Lyris, okay. Are there new therapies for pain? It depends on what type of pain you're having, my friend. Are you having bladder wall pain, pelvic floor pain, vulvar pain, skin pain, deep pain, nerve-driven pain, muscle-driven pain? Sherry says, I've heard colloidal silver is regimen. Hell no. Colloidal silver is not in the regimen for IC. Colloidal silver, please, people, let me debunk this once and for all, is in no way any sort of thing you should be using if you have interstitial cystitis. I know that there are companies that are selling it. I know that there are patients who are using it. It was a fad in IC 20 years ago. We have not a single ounce of data or information that suggests that colloidal silver is beneficial in any way, shape, or form. What we do have is major toxicity with colloidal silver to the point that the FDA issued an alert for it several years ago. It is considered one of the most dangerous supplements on the market. So please, please, yes, there are going to be people on Facebook online who are going to be promoting colloidal silver. In my opinion, I don't think you should touch it with a 10-foot pole. I certainly would not. There's no role for metal in your body, much less bladder function. And when you think about what the bladder does anyway, it stores toxins until you can pee them out. And if you have okay, seriously, if you've got a wound in your bladder and you got silver floating around, that silver is going to get into your bladder wall. You know, some people who use colloidal silver too long, their skin turns silver because the silver is building up. I can promise you, you do not want that to happen in your bladder. So please say no to colloidal silver. Victoria says, when posting about IC Awareness Month, and there's an option to add a donation button, but the IC Network doesn't have an option, so I was wondering if I could add the IC Network page or store. Certainly, because we run IC Awareness Month. We have for years. We're the only group that has. And you can make direct donations to the IC Network through our store. Obviously, many patients will want to support research, and I completely support that. And on IC Awareness at icawareness.org, I give the link to, in fact, I was just updating it the other day, to the Beaumont Urology IC Research Program. They are the best research team in the world, in my opinion. They were based in Michigan outside of Detroit. If you want to make a donation for IC, I say you donate directly to the researchers rather than a national group, whether it be the ICA or the IC Network. I think that if you donate to the researchers directly, the odds of all of that money going to that research team is very, very good. And of course, we love donations because IC Awareness Month costs to develop everything. But really, the priority should be research. It's a very low budget effort for us. The company that was going to sponsor IC Awareness Month this year, which was Equinox Pharmaceuticals, their clinical trial failed in July, and they suspended all of their IC outreach and fired all their staff. And obviously, the money we were hoping to have for IC Awareness Month is now gone. So it is a bare bones grassroots efforts, my friends. Mary says, what kind of tea? It is a pumpkin spice rooibos tea, and you can find it right on our website in our shop. Darlene has frozen feet and peripheral neuropathy. Yes. What do I have in my tea? Just a little bit of creamer and a wee bit of sugar. I'm trying to keep my sugar intake way, way low. Before I would have put two big teaspoons of sugar in there. Now there's maybe a half a teaspoon at the most. Sherry says certain root beers have no caffeine, but has carbonated soda in it. It's not so bad for me, but then again, I'm rarely drinking it. What is the most harmful for IC, the caffeine or the carbonated soda? The caffeine for sure is by far the most irritating because that is neurostimulatory. That is going to turn your nerves on and give you more frequency and urgency. Our goal is to calm the nerves, not provoke the nerves. That is indeed what caffeine does. So if you are IC subtype 1, IC subtype 2, or IC subtype 5, or IC subtype 4, our goal is to not trigger nerves. We want to calm them down. So caffeine should be off of your list. Doing a decaf is essential. And let me just give you a warning about green tea. A lot of people think green tea is good. Green tea is as bad, if not worse, than coffee because green tea is extremely acidic and tends to have a lot of caffeine. But even if you do decaf green tea, it's still going to irritate your bladder because it has a lot of acid level. All right, let me go back to Facebook here. Catalina says, can you please, I'm going to YouTube. Can you please explain to me why symptoms increase right before your period? I can. Oh, I can. Alrighty. So this mucosal barrier, this turquoise area, is estrogen dependent. So when you have more estrogen, your body is capable of producing more mucus. When you have less estrogen, your body is capable of producing less mucus. So one of the reasons why women flare during their cycle is they flare at moments when their estrogen levels can be very low. Although some patients are funky and it's the opposite. But generally, the day that you ovulate and or a couple of days before your period, your bladder wall your mucosal barrier is not quite as thick as normal because of the loss of estrogen. Therefore, your bladder is a little bit more vulnerable. And that, my friends, is a hormone-induced IC flare. All right, last call for questions. Last call for questions on Facebook, on YouTube. I am so sorry that I was the one who had to share with you the news about this eye study and Pitocin. I hated doing it. But it had to be done because you have the right to know. And the fact that the Emory Eye Center specifically said in their letter that if a patient with Elmeron is taking medication and also has eye problems, they recommended stopping the medication. And that is indeed exactly why I wrote the blog that I wrote and I announced it last night and we're doing the research because you deserve the opportunity to know that information and make decisions based upon that information. It breaks my heart that some of you were scared, and I don't want you to be scared. This is rare at this point in time, but it's worth your knowledge. And it's worth us, as part of IC Awareness Month, to get the word out. Okay? So, but listen, I always end these in two ways. And again, I'm waiting. I've got, a couple more minutes. I'm happy to take a few more questions. But the single most important thing you hear from me in every single meeting is, this is not your fault. This is not your fault. You have done absolutely nothing wrong. There is no shame. There is no blame when you have pelvic pain or bladder pain or a bladder injury or bladder illness. It sucks that it's not a broken arm. A broken arm is easier. It's easy to talk about a broken arm. It's a lot harder to talk about an injured bladder or an injured pelvic floor muscle. And we IC patients, we often hide it. We are known for kind of suffering in silence at home alone. I certainly did. We start to wonder what's wrong with us. We start to wonder if we're damaged goods. We start to wonder if we're being punished. In my 20s, as I was going through some of these funky things, I truly thought that it was my fault, and I carried a very heavy burden, a very heavy load. I became very depressed and very anxious. And I'm telling you, when the first studies that came out showed that there was a genetic connection, the light bulb turned on for me, because hello, my sister, my mother, my grandmother, my aunt, my cousin have all been diagnosed with IC. And it was at that moment that I learned it was not my fault. And I cannot begin to tell you how important that was for my emotional health. I carried a tremendous burden. I did not think I was worth loving. I did not think that I was lovable. I did not think that I could be a good mother. I did not think I could be a friend. I was immersed in trying to understand the hell of my body and why I had IBS and why I had IC and why I had vulvodynia. I spent most of my 20s either in grad school or at home laying in bed with cramps trying to have a bowel movement without crying because my IBS was so bad. Okay, I am happy to tell you that I am symptom-free now. Symptom-free. I rarely have problems now. So that doctor who told me, hey, you will forever be a burden on your family and you will always live in pain, get used to it, he was wrong. He was not only wrong, he was effing wrong. I want to swear. I swear a lot now, and I apologize, but I just have to say that in the last 2 years, for a very obvious national reason, I tend to swear more. He was wrong. But when he said that to me, when he said, you will forever be a burden on my family, that is the moment that I turned this around. Because I went from hiding at home, crying my eyes out, to fighting back. And I said, I will prove you wrong, you son of a bitch. How dare you say that to me? I still have my head. I still have my brains. I still have 3 college degrees. I have my hands. I have my arms. I will prove you wrong, you son of a bitch. I'm not kidding. I was outraged. I started my first support group from my bed a month later. I started the IC Network a year after that. And I was still in pain. Obviously, I was still in pain. But the secret is being involved. You gotta be ready to kick ass here. You gotta be an advocate. And when you take that burden off and you go, wait a second, I'm hurt. I haven't done anything wrong. I'm hurt. You have the right to ask for help. Listen, if anybody in your family was hurt, you know you would be all over there helping them. But why is it we with IC, we don't think we deserve the same thing? You deserve the same thing. If you are struggling, you ask for help from your family. You have done nothing wrong. Okay? So take the shame, take the blame away, and I want you to be proud of yourself. You have never worked as hard as you are working at this very moment because you have been in pain and you have been struggling. You should be proud of that. Every single day, I need you to do 3 things. I need you to do one little thing for your soul. Do something that comforts your soul. Whether it is going out and taking a hike and hugging a redwood, as we are known to do here in California, or going to church, or listening to Joel Osteen, or meditating, or whatever. Do something that nourishes your soul and your spirit. Okay? Then do some small thing every day for your bladder and for your body. So whether it's eating right, trying a new food, saying no to Starbucks, getting, taking a warm bath for your muscles, again, doing meditating, going out and walking around the block. Do something for your body. Just do a little thing for your body every day. I'm not asking you to go run a marathon. Seriously, just walk out the house, walk up and down the street a couple of times. I'm happy with that. And then last but not least, do one thing to improve your noggin, to improve your knowledge of IC. Read. Don't read CNN and Twitter and Facebook, as I have been doing a lot the last year. And boy, my productivity's gone way down, but I wake up every morning going, what's happened next? I have to stop myself from doing that. I stepped away from that and I went to the journals and I found the letter to the editor. And that's what began this whole thing. So come to our website, read a blog a day, read an article a day. You don't need to read the whole thing. Go to the ICA website, read something on their website. What I don't want you to do is I don't want to use Facebook and I don't want you to use a support area for your knowledge. Seriously, I need you to up your game and I need you to read a real article, and you will find those real articles right on our website. All right. I curate all the information on our website. I work my ass off on it, trying to give you the best information. And we have been rated #1 by Harvard Medical School and the University of London for the quality of our information on IC. All right. Last but not least, my friends, we have a magazine. It is called the IC Optimist. I've been doing this for 15 years now. In fact, this is our 15th. This is issue #2 of our 15th year of our magazine. Articles that come out in our magazine are not released on our website for about 6 months. So if you want the real cutting edge on IC, you want to get our magazine, and you can get it for as little as $25 a year when you become a member of the IC Network. And that is indeed what pays for these free support groups. There's no paywall on our website. It is entirely free. It has always been free, but it still has costs and expenses, and we pay for it with this. So please, please, please come be a member of the IC Network. You will see this is our summer issue. It was released 3 weeks ago. And what I have in here is Inside AUA 2018. And even though that's a small title, I have an extensive summary of the class they taught on IC to other doctors with case studies. Very, very good article. But we also have an interview with the CEO of the company doing next generation DNA sequencing. Fabulous interview to help you understand why this test is now going to become standard. In fact, this is already standard. The MAP Research Network, which does the IC research for the National Institutes of Health, is already doing this. They use next generation DNA sequencing and discovered that IC patients are deficient in good bacteria. And we have an abundance of perhaps some more pathogenic bacteria. They're the ones who discovered that many IC patients having IC flares actually have Candida-driven flares. So they have an overgrowth of fungus in their urine. And in fact, traditional urine tests will not find Candida. However, next generation DNA sequencing will find Candida and tell you if, in fact, you could have a Candida infection triggering your flare. And again, getting back to this eye study, they did next generation DNA sequencing in these eye patients to see if they could find anything pathological in them too. This is very standard of care now very, very affordable, and can tell you once and for all if perhaps you have some sort of chronic infectious process happening in your bladder. And so we now recommend it for everyone. If you have other signs of infection, just go out, you just read about it. It's okay. Where's my thingy? I cannot find it. You can learn more about next generation DNA sequencing on our website, bladderhealth.org. That is a new website that I built this summer for it because I am that excited about it. I'm just excited that we have a really, truly reliable test now. Some of the other testing is just not as reliable. This is a slam dunk reliable. All right, my friends, last call. Any last questions? Thank you, Victoria. Christina just got yours. Awesome. Sherry's telling Marianne, Jill said Elmeron is bad for our eyes. No, honey, actually, I didn't say that. What I said is researchers at Emory University have now found and believe that some patients who have taken Elmeron for long periods of time may in fact be developing some retinal eye conditions. Elmeron is not bad for everyone. Elmeron, this is considered rare at this point in time, but it is new. It is important that we know about it so that if you are having eye issues, you know what to do and you go to the doctor. Alrighty? Again, feel free to call me if I've missed your question. Please do not take that personally. At this point in time, we've had 233 comments on Facebook alone. Would have been impossible for me to answer every question. Do not take that personally, but you are absolutely welcome to give me a phone call. In fact, you know what? Even though tomorrow is a holiday, I'm going to try to answer the phone at least part of the day because I'm going to assume that some people are going to want to talk about that. So 1-800-928-7496 is our number. Please also remember IC Awareness Month, publish and share our IC Awareness Daily Facts through all of your social networking. Get over there, enter the poster contest, enter the meme contest, nominate your doctors who have treated you well, your nurses, your physical therapists. We want to recognize the doctors that are good also, okay? Woo! I wish you the best. Carry hope in your heart, my friends. We will talk again. Have a good holiday. Thank you, Betsy. We're off of Facebook now, but we're still on YouTube. You're very, very welcome, Betsy. I just felt quite honestly that I didn't have a choice. I felt that you were entitled to know this information, and personally, I would have been outraged if this information had been hidden from me as a patient. And so I felt you were entitled to know. And let's try to figure this out. We'll do it together as always. All right. I'll talk to you later.